So Nick, can you describe to us what an EPA is?
Sure. I think it's really important, Joe, to bear in mind that an EPA, entrustable professional activity, describes work that is being done regularly in clinical practice. So it's important work, it's work regularly done, and EPA describes that work. It's not describing a doctor, it's describing work that a doctor does.
And in the national framework we have 4 EPAs
We do,
for
yes.
prevocational trainees. Could you tell us what they are?
So there's the first EPA is clinical assessment, so that's taking a history, doing an examination, formulating a diagnosis or problem plan, a management plan. It's EPA 1. EPA 2 is acute deterioration of a patient. Importantly, that could be acute deterioration in a medical sense or post-surgery. It could be acute psychiatric symptoms developing, signs. It could be, in my case, I worked in a hospice, it could be the sudden onset of the terminal phase earlier than was anticipated. So it's acute medicine, reacting to something that's happening immediately and demands attention. EPA 3 is about prescribing. Not just prescribing drugs, it obviously includes drugs, but blood products, water, fluid balance, anything where you're giving instructions about something like a drug or an intervention being done. And the final EPA is about team communication. So this could be discharging a patient, writing a letter to the GP. It could be ringing the GP and having a conversation. It could be handover at the end of a shift to another doctor. It could be a junior doctor being asked by his consultant or her consultant to contact and get a consultant opinion about a problem. So it could be get a surgical opinion please on this patient in our medical ward, that sort of thing.
So absolutely they're about describing the work that junior doctors do every day.
The work that junior doctors do. Now of course to perform that work, doctors need certain skills, attributes, professional behaviour, they need competencies. Mm-hmm. Those are all attributes of the doctor, and they will need those to perform the work described in an EPA. So the two concepts are related, doctor qualities and work that needs to be done, and they intersect, but an EPA is about the work.
Mm-hmm. So I've heard some people talk about EPAs in terms of assessments. Can you tell us a bit about that?
It's so common. People hear EPAs and think, assessment, Now, go back. EPAs are about work, regular work, important work that needs to be done by the PGY1 or PGY2 doctor. Mm-hmm. A doctor doing that work can be observed, they can be formally observed and assessed in that performance of the work. And so an EPA can be assessed, but an EPA itself is not the assessment. An EPA can have an assessment approach described to do the assessment of the EPA.
Right, okay. So in terms of term supervisors and others, registrars and other doctors and other maybe pharmacists and so forth who might be doing EPAs, what are the key messages you would like to give those individuals?
I think, firstly, the framework has been designed with those involved in the design fully cognizant of the pressured situation that applies in all health facilities in terms of pressure on time. So the idea of this is not to add a huge burden in addition to the already stretched resources. EPAs are about work that is happening every day anyway. Yeah. Before we had the framework, EPAs, though they weren't called that, but that work was being done. Good or bad, it was being done. And what we're trying to do with this is just put a framework around it to make growth in the performance of that work more systematic, part of what's done and looked at. So I think a key message is that those EPAs are happening every day. You might have planned with your PGY1 or 2 doctor to do an EPA assessment tomorrow. Tomorrow comes along and it's a disaster, the pressures are all on and no one's got time to do anything. All right, don't do the EPA assessment today. Let's reschedule it for another day, because it's work that's happening every day anyway, so there'll be plenty of opportunities to find that time to do it. Also, although we are saying that the supervisor or lead clinician or specialist, so a senior person, needs to assess one EPA in each term, it's very important to recognise that a nurse could assess an EPA, a registrar could assess an EPA, a pharmacist could assess an EPA. Anyone who is appropriate for that particular EPA could actually do an assessment of it. So spread the load. We recognise resources and time are precious, so spread the load, and that would be good. Peers can do EPAs to practice. No reason why not. Yeah.
So can you tell us the difference between entrustability and competence?
Yes, I'll approach that with two sort of observations which I think are important to bear in mind. Competence, as we've said, is about the doctor. It's looking at a set of observable behaviours that a doctor exhibits. That's how we... And so with competency-based frameworks, what tends to happen is they're atomistic and reductionist. So you look at a task and you break it down into a list of 20 important steps, and you tick, yes, I saw that, tick, 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 and so on, and someone gets 16 out of 20 ticks in their competency and a few notes on the bottom. So that tends to break the tasks down into observable chunks. EPAs are synthetic. They bring together competence, attitude, professionalism, skills. They're all woven in. And what you're looking at when an EPA is assessed is much more of a global performance, and the assessment is based on this concept of trustability. And if you think about it, it's what doctors have done for years. You get a new intern on your ward. In the first 2 weeks, you're sort of working out just, whether if this person calls me, am I feeling relaxed because I'm confident based on what I've seen that, they're telling me what's going on, and or is my heart racing because what I've seen in the last 2 weeks really doesn't give me any comfort at all. So this is the concept of entrustability. It's what doctors for years have been doing intuitively. This is a language around that. Would you trust that doctor to perform the task that you've observed if you were down the corridor in your office, reachable but a bit further away? Or would that be, no, what I've observed, I'd want to be standing right over the shoulder, having a look? Or am I so relaxed about what I've seen that actually if I was at home and this doctor did that, I would be, and then did a phone call, I would be confident that what was going on was good. And so that's direct supervision, proximal supervision, or remote supervision kind of thing. And it's entrustment. I trust that what I've seen on that day in that place with that patient at that point of time, that's good. What I saw, that whole performance. And it might be that the performance you observe shows partial entrustability or direct supervision being more required. And it might be that the reasons for that is a knowledge deficit, or it might be the reasons for that is you didn't like the cultural safety things that you saw, or it might be the reasons for that were to do with a lack of a particular skill that was important in terms of examining a chest or something like that. Or it might be combinations of those things, but all of that gets folded in to the feedback and the conversation that's aimed not at saying you're a good doctor or you're a bad doctor, but this is what you could do to make your patient care better, the outcomes for patients better. And that's where the shift is coming.